All right, welcome everyone to the first installment of our Children's Mercy Bioethics Alumni Speaker Series, where we will be featuring work in pediatric bioethics from graduates of the Children's Mercy Certificate Program in Pediatric Bioethics. As you can see from the loop slides, today's session, there are no disclosures to share. Continuing education is available. You can use the QR code when that slide comes up in a moment. We will be taking questions for Dr. Wolfe today through the chat or through the Q&A. Please note, though, that there is a lag, and Dr. Wolfe will be a little bit ahead, and then it will take a little bit of time for the questions to reach him. So please enter those as early as they come to mind, and we will be sure to take them in the order that they were received. I am thrilled to introduce the first speaker in our Alumni Speaker Series, Dr. Ian Wolfe. He is the Director of Ethics at Children's Minnesota, but before that, he was a Pediatric Ethics Fellow with us here in Kansas City at Children's Mercy, and was a graduate of the certificate program in the year 2020, a rather uneventful year and second half to his fellowship and training in the certificate program, as he can tell you. Dr. Wolfe is a prolific scholar, educator, and clinical ethicist. He has backgrounds in nursing and philosophy, and he puts those together in unique and interesting ways. He also serves as the editor of the Journal of Pediatric Ethics. And Dr. Wolfe, I invite you to feel free to give a plug for that at any point in your talk. It's an excellent journal featuring some of the best scholarship in pediatric ethics, and he welcomes submissions of all kinds. And I would encourage those of you in the audience who are looking for a new venue for that latest piece that you've written or case analysis, send it to Dr. Wolfe and have it considered for that journal. Today, he's going to be speaking to us on the topic Patient, Fetus, Neonate, Child, Ethical Complexities in Fetal Care. He'll be speaking for roughly 40 minutes or so, and then we'll have plenty of time for Q&A. And again, feel free to enter those questions at any point in the talk. Without further ado, let's turn it over to Dr. Wolfe.
Thanks, Jeremy. Thanks for that introduction, and I'm glad to be here kicking off this new series. I'm always excited to talk about this topic because I kind of cut my teeth and got my intro into fetal ethics space there and at Children's Mercy with Dr. Brian Carter. So thanks everyone for joining today. So I was already introduced quite well, and yes, the Journal of Pediatric Ethics is an open access journal. You can go to the website. If you just Google Journal of Pediatric Ethics, it will come up. It's all of our past issues are on there, and we accept submissions on a rolling basis. We do 2 issues per year. We are indexed in Crossref and working on our PubMed indexing as well. So this is my disclaimers and confidentiality from Children's Minnesota. I have nothing to disclose. And here are the objectives. And what we're going to really do today, I usually like to do roadmaps because I've set this presentation for a broad audience. So, recognizing there might be some folks who have a little bit of experience in fetal ethics and some who have more experience, but I'm going to kind of talk about the broad overview of some of these things. And as always, I like to bring things into the practical sense of how do we think about this, how do we navigate them. So I'm going to go over some of the major concepts, citing some of the relevant and I think seminal literature in the field that you can reference and read in greater detail as you wish. And then hopefully we should have plenty of time for discussion, which I like. So the first thing is really saying, well, what are we talking about here? Because we hear about fetal intervention, we hear about fetal health, we hear about fetal care. And, to grab right off the front page of the center that I'm involved in and a part of, the Midwest Fetal Care Center here at Children's Minnesota in a partnership with Allina Health, right there is, comprehensive maternal fetal medical care for you and your baby. So we're talking about really comprehensive care. So during this talk, I'll be talking a lot about fetal intervention because that's really gets to some of the ethical issues. But really, we're talking about this in a sense of all types of fetal care. So just assessment, counseling, to scans, diagnostics, to also interventions here. So this is a whole space, and those of you who work in the fetal space will know that well, because you get as we open a fetal center, it's not just about the interventions, but you tend to get a lot of referrals where there's complex diagnoses. So, and to give our viewers a little bit of a more specific of what we're talking about when we think about fetal intervention, there's a number of different types of interventions. I think some of the most popular or the most well-known ones are twin-to-twin transfusion treatment, where they do go in and sever some of the vessels, depending on which technique by center, and that hopefully the goal there is to provide benefit to both fetuses. Oftentimes, this is where some ethical questions come up, that one of them benefits more than another one, and one is not viable. Another of the most common ones is our what was originally some of the first, which is our open uterine repair for myomeningeal. As you can see there, surgery on the fetus while still in the pregnant person's body, and then now mostly it's a fetoscopic version of that same repair, and then one that's emerging a little more here in the U.S., which is Feto, which is going in to provide an occlusion in the trachea in utero in hopes that it will spur lung growth to avoid not so much repair the congenital diaphragmatic hernia that's existing there, but reduce need for ECMO. So not a lot of these are necessarily curative, but they have some benefit. And then, of course, fetal MRIs and diagnostics are some of the other more common things that we do within a fetal intervention and health space. So we're going to start with what I'm calling an elephant riddle, and you can weigh in on the chats of whether this was a horrible riddle or not. But I wanted to start with this question that I think is really key for fetal health ethics, which, what is both a patient and not a patient? And of course, that is a fetus. And why I call it the elephant riddle, because really it's, these days, especially, the elephant in the room, right? And the elephant in the room is whether this is, we consider the fetus fetal patienthood, or whether it's personhood. And this I like to use as sort of the start of where we think about ethics in the fetal health space. Because when we're talking about doing health for the fetus, we're having to ask these important questions about who is the patient. And it inevitably brings up questions and confusions in language and terms about between clinicians, staff members, the parents, and how we put identity, or how we view identity of that fetus in different ways. And that brings up, I think, a lot of questions. And so the way I like to think about this, and I'm happy to hear disagreements as well, but I'll show some other thinkers who have really thought through this. This is kind of taken from Ryan Antiel, who's, I think, done a lot of great ethics work in fetal intervention, thinking about patienthood in more of relational terms, right? So patienthood is something that is based on a relationship between somebody who's providing healthcare, versus personhood being kind of an intrinsic thing. So I think of this in terms of like a state of practice versus a state of being. So in practice, we kind of confer patienthood. There might be some intrinsic qualities that make somebody a person, or something a person. Antiel talks about Lindemann, who I thought was interesting to note, that thinking about pregnancy in terms of the process of initiating the fetus into personhood, right? So that process that a pregnant person is going through as they continue in their pregnancy, it's kind of a developing personhood as we start to confer personality sometimes on the fetus, or however the pregnant person is identifying that fetus. There are also some philosophical religious ways of thinking about this too, and this is just a broad overview. Obviously, there's a lot more in depth here, but for example, in Islam, there's often discussion about the time of the quickening being when ensoulment happens. And that's when the fetus becomes considered a person in some regards. And in Christianity, at least in the U.S. Christianity movements, there's a wide range of how people might view personhood within the context of pregnancy. Judaism, there's discussions around, the birth of the head, so right, the coming through the vaginal canal, or personhood at times of birth. And personhood has been changed a number of times throughout history. If you look back into Roman times, there's even considerations of people not really gaining personhood until they were at the age of 12, or survived a sufficient period back when child mortality was significantly high. So a varied range of ways that people might consider personhood. And then we get into a little bit of this moral versus legal personhood, which, generally speaking, morality often informs legality, and it gets a little more complicated these days, of course. But what I want to say really that is fundamentally the way to think about this, that I think about this so we can kind of move forward with the talk and get this sort of elephant in the room out of the way, is that personhood I really think of as a moral claim. Potentially a legal one too, depending on what state you're in these days. And we're going to talk about really here the fetus in terms of patienthood, right? So we're really thinking this is an ethical consideration, right? So really thinking about this in terms of personhood, distinct from personal moral views, right? So it's important to know how the patients view personhood when you're counseling within the fetal space. It's important to know you as a clinician, how you view personhood, so you can help navigate yourself in working there. But in terms of sort of secular ethics here, we really think about this in consideration of patienthood. And that's really what I'm going to be focusing on there today. So just to validate that there might be several different types of moral claims of personhood, and those can be very valid based on that sense of morality. We are focusing really on this idea of patienthood in the ethics considerations going forward. And some of the first work around this idea of fetus as a patient really came from Shervinack and McCullough. They have a number of articles over the years talking about this idea of the fetus as a patient. And often they start this concept of morality in clinical practice, that it's the obligation to promote and protect the interests of the patient, really saying that is the sort of undergirding of all morality in clinical practice, is that relationship to the patient, that obligation to promote and protect the interests of the patient. And so they talk about when somebody or when something becomes a patient, it's, they say a human being without independent moral status should be regarded as a patient when two conditions are met. When that human being is presented to the physician, they use physician, would open that up to clinicians, when there exist clinical interventions that are reliably expected to be efficacious and result in a greater balance of goods over harm. So this idea of proportionality that we think about a lot in pediatrics, that proportion of burden to benefit. And why isn't, you might ask, viability a consideration for being a patient? Well, Shervinack and McCullough consider this and say that, well, viability is not an intrinsic property as it relies on biological and technological factors. They say viability exists as a function of biomedical and technological capacities, which can be different in different parts of the world. Obviously, viability within state statutes becomes very ambiguous depending on what states and where you are. And I think even within one state, viability can mean different things at different institutions, as we see, survival of premature, especially premature children, vary between institutions. And so some clinical ethics considerations here are that a fetus, and this is coming from Shervinack and McCullough, that a fetus cannot meaningfully possess values and beliefs. And they list a number of reasons for this too. But when we think about this in terms of also similar to a neonate, right? We don't really know that they have the meaningful ability to possess values and beliefs. Now they have potential ability to possess values and beliefs and will have some, right? And so we don't really have any autonomy-based obligations towards a fetus in this sense, right? So in a general sense, we don't have autonomy-based obligations to them. They have health-related interests, though, but only when the fetus is a patient. So this requires that the fetus is being presented as a patient. And so these are what they say that we have beneficence-based obligations towards the fetus, and they talk about this in terms of three prima facie obligations: beneficence-based, um, autonomy-based obligations to the pregnant patient, and beneficence-based ethical obligations to the fetal patient. Right. So the pregnant patient has the autonomy and beneficence-based obligations from the clinician towards those, and the clinician towards the fetus finds beneficence-based obligations. And they say this is because being a patient means that one can benefit from the application of clinical skills of the physician. And importantly, fetal patienthood does not imply that it is a patient separate from the pregnant person, right? And I think you've noticed up in this point, I've been talking about the fetus as this sort of separate entity. Of course, we know that's not the case, at least not currently in our technological capabilities. The fetus then really has dependent moral status, right? This is this idea of the dyad, right? We think of this in terms of the pregnant person fetus dyad. They are of one body. And so this leads us into some pragmatic considerations, right? So the pregnant person has moral primacy still in most states. You'll see what I'm talking about here, meaning that they are morally people and legally people, and they have moral primacy. And one reason is because interventions toward the fetus inherently require interference with the body of the pregnant person. And so we owe pregnant people respect for autonomy considerations, i.e. liberty, and that should be prima facie. It means that should be first face, even at the expense of what we might consider a bad decision for the fetus in general, right? So people can make bad decisions similar to pediatric ethics. Parents can make decisions we might feel is bad. It's a little bit different here because in order to interfere with the fetus, if say we even did have obligations towards it differently, we would have to override the autonomy and liberty of the pregnant person. And generally, we cannot override liberty interests of people without good cause, of course. So if they have impaired autonomy, those kinds of things that we often find in the adult world or even in adolescence where there's impaired capacity or something like that. Now, interestingly enough, there are a few states that will commit pregnant persons for things like substance use disorder where they still may have quote unquote capacity. Interestingly enough, even the free state of Minnesota is one of these states that will, and our surrounding states of North and South Dakota and Wisconsin, which is an interesting little regional history that I'm not completely sure about, and then Oklahoma. And so what these states have said is that in some cases, although not very many, at some point there's a benefit to overriding a pregnant person's liberty in the case of substance use disorder in pregnancy. So kind of a complicated thing that we will not get into today, but happy to take questions on that in the end. One thing when we're thinking about maternal or fetal interventions is this idea of maternal-fetal conflict. And this concept comes up quite a bit in the literature talking about this. And this is really where the interests of the fetus and pregnant person differ or at odds. So surgery where a fetus appreciates the benefits with all the risk on the pregnant patient, right? So I'll kind of explain a little bit what I mean. This does assume fetal patienthood though, right? So this is only in a case where the fetus is being presented as a patient and being treated as such. And this is, and also kind of assumes this separateness, which makes it a little bit uncomfortable. But just to note that, the fetal patient, and why I say in the beginning that what is both a patient and not a patient, because a fetus might exist as a patient when a pregnant person presents that fetus to a clinician for some assessment for potential beneficial treatment or assessment, but then can relinquish that status when they are not presenting that, right? So a fetus can be at sometimes a patient and sometimes not, depending on the autonomy of the pregnant person. And tensions really exist between obligations to the fetus as a patient and pregnant person as the primary moral agent, right? And this is where some of this tensions come up in the fetal space, even when a treatment is considered beneficial, right? And so it kind of puts everyone at odds. And to kind of elaborate a little bit more on this, I'll go to kind of a big moment in fetal history, which is the MOMS trial, which was, and this isn't a picture from the MOMS trial, but this is about myomeningeal repair in utero. And the things that came up there that were interesting to consider are that we're talking about putting a pregnant person at risk where the benefits of the surgery will only be felt on the individual future child. And so why that brings up maternal-fetal conflict here is how much risk can somebody have or take on when they're not getting the benefits of the risk of that intervention? And what about when it's not a terminal condition, but it's meant to reduce disability? And it brings into this other question of the input of technology into the space. And so some considerations we need to go through then are this idea of disability, hope, and the technological imperative. Hopefully the sound is continuing to stay steady here. And this is an uncomfortable space, I think, in tension with a lot of disability ethics. Because the focus of some of these interventions, such as myomeningeal repair, is to reduce disability, meaning that it's not life-saving, right? So myomeningeal repair is not necessarily a life-limiting condition or a lethal condition. And so we're putting a maternal body at risk for benefits simply to reduce, and I say simply in quotes, to reduce some disability. So some improvements in mobility, some improvements in reduction of need for a VP shunt, those types of things. And it really gets to this idea of how we value medical interventions. How we value or how we apply value to medical interventions. And Mark Blyton has written a couple of really good papers on his experience in talking to a lot of different families around this, and noted at one point that parents seem to be more against disability than for the surgery, right? So this idea of how much is disability weighing into decisions on a value-laden perspective, and how that maybe influences parents to choose surgery. It really gets into this idea of how society views disability and even how the disability community views identity, right? As we start to find sort of fixes or abilities to reduce these things in society, how does that affect people's identity in potentially negative ways in the disability community? And Mark Blyton, this other article he writes, really, I think, speaks to this even more, because this gets into this idea of parental hope, right? Because at least in myomeningeal, these are severe but non-lethal malformations. In twin-to-twin transfusion, there's a lot of hope there because sometimes both twins could be affected, and this technology might give you a chance to save both. Often only save one. Sometimes with big risks, you risk complications to the pregnancy, but also complications of maybe losing both fetuses. So you have increased risks to decrease disability, and it's not life-saving. So this is really complicated from an ethical perspective, right? How much value, negative value, we're putting on disability to justify increased risk to a pregnant person taking all that on. There's also risks to future pregnancies, et cetera. So, the fetal myomeningeal repair improves mobility, potentially reduces bowel and bladder issues, and decreases the need for a shunt. But now you're putting the pregnant person at risk, potentially the fetus at risk as well. And there's a really big question of how do we balance those benefits and burdens? And Mark Blyton talks about this in terms of hope and restraint. We do view the pregnant person, the fetus, as a dyad, but it brought up those really interesting questions when we're thinking about hope. What are our clinical obligations towards the fetus? And hope is a powerful thing, and And it's not just about the interventions, right? Our diagnostics bring up a considerable amount of hope. Right now, we see this thing, and now we have identified this problem, and it brings up these questions of how do we think about fixing this, or what can we do about it? Um, and hope can lead a lot of parents into feeling that sense of duty to do things, right? So parents sometimes are balancing the sense of duty, the sense of risk, sense of hope, and then with advanced technology, um, thinking about how we make decisions with all that, right? And so between the twin transfusion syndrome, I think is a really good one to think about in that context, because now you have a parent who is faced with, well, if we do nothing, potentially both fetuses are at risk. If we do something, you could potentially save both, potentially save one, potentially lose both, potentially have complications. I think there's a question of how hope really plays into the decision-making context there. What parent can say, I don't want to do that? And of course, we do have parents that don't opt for this, but I think when that plays into the decision-making process, achieving informed consent in the true form becomes quite complicated. And for fetal, this is complicated because once you have the ability, you are essentially in a whitewater rapids, moving, and you can move yourself a bit or avoid the boulders, but it's hard to really get out of the water. And these authors wrote this, I think, great paper on this idea of precarious hope, and how we offer these experimental fetal therapies outside of the initial studies in humans. Because a lot of these things, right, it's not just about like the upcoming ideas of prenatal gene therapy, where you are making this intervention and you're not really sure what that's going to do long term. But I think even that having the diagnostics, having the ability to do these, really throws us into this whitewater rapids where, because we have it now, we have this this option, right? And that option is there, and so at tension with then how we make decisions. And this gets really complicated because I think, as I'm often fond of saying, the more we know, the less we know, right? Now we have this information. So genetic testing is often about this too, and our prenatal diagnostics are good, but we don't always know everything. So now we know there's some issue, and so now we feel compelled to maybe do something about it. We have a potential benefit, and that changes how we make decisions, because it brings in hope, uncertainty, and knowledge of potential benefit, right? So now we as we know more, we know less about how those outcomes play out, because we have something to do that can maybe do something and provide some benefit without sometimes an understanding of how that's going to really play out down the road. And so we have this idea that, right, because doing is always better than not doing. And this really gets into this idea of what becomes experimental and what is innovative. And I think one of the big examples here is amnio infusions for early onset anhydramnios, and the renal anhydramnios fetal trial for bilateral renal agenesis, where theoretically we have this thing, and so we start a study, but then turns out we have survival with high morbidity, and so this trial was eventually stopped, and partly because we were able to be successful in saving some of these children, but the significant morbidity that they then lived with was so high that I started to question, should we even do this? And I did hear from a mom who had two children, one fetus, one never survived, diagnosed with this, and they went through the RAFT trial and talked about their experience of having now a newborn who needed to be on peritoneal dialysis, and what the sort of quality of life became after that. And that experience led them to not choose it for their subsequent fetus that was diagnosed with it. And again, that just brings in this question of a technological imperative of and hope of, when we have these things, we are feeling compelled then to do them. And this gets us really to the technological imperative, and Dr. Carter and Cummings wrote a great paper about this. It's a technological imperative. I think it's something that most ethicists have been thinking about for quite some time. And it's really this impetus to utilize all available technology to diagnose and treat patients. The authors cite Bjorn Hoffman's concept of a self-perpetuating force that drives the development, production, and adoption of technologies, even in the face of limited evidence or potential ethical concerns. This technological imperative and its accompanying imperatives of commitment and possibility may be familiar to neonatology intensivists and those in pediatric adult care. And I like to think about this in this sense of technological optimism meeting a parental sense of duty, right? We have this high optimism in technology. Technology will save us, right? There's always something we can do. And that parental sense of duty of what would a good parent do? It is my duty to do everything for my child. What does everything mean is sometimes what we have to then ask, right? Because a good parent in some people's mind might be to do everything. And when you couple that with knowledge of knowing now something that is wrong, but not really knowing what that's going to look like postnatally, we start to be compelled to do more things to benefit the fetus/future child, but at the risk of all the risk being felt on the pregnant person. And I think we've all seen the sort of rationales here heard in practice. We've been treating this patient for so long, we can't just stop. We are trained experts. This is what we do. We have to try everything. I won't read the entire list. But this is in Dr. Carter's paper, and I think when I read them, I was like, yep, I've heard every single one of these. So something to think about how this weighs into prenatal counseling, how this affects how parents show up to that counseling, and really requires us, I think, some thought about this. And then we get into risk and benefits, right? And that's the question here really is who benefits? We are talking about the future child benefiting from most of these surgeries. I think it's disingenuous to only focus it on that because a child is part of a family. Benefits to that child's quality of life, assuredly benefits the family as a whole. There's also economic and social factors around a child who maybe doesn't need as much adaptive equipment in their future. So there's a lot of different considerations to that. But again, when coupled with that sense of parental hope, what parent wouldn't do whatever it took to benefit their child? And that question is a good one, but it requires clinicians to sit back and consider their sense of who's benefiting, how much, and how much do we allow this to go forward based on that analysis. And that's really, again, who bears those burdens and risks. There was this ethical framework that was developed by these authors here, which I thought was really good and just a new way of thinking about these cases, especially in fetal therapies, right? Looking at it from a sense of the benefits for the fetus plus the risk for the fetus, benefits for the pregnant person plus the risk for the pregnant person, and the societal value. They talk about a number of considerations about how this might play out, because inherently in some of these fetal trials, there is a need to consider societal considerations. And I think, I don't talk about it in this talk, but specifically when we get into prenatal gene therapies, this is really going to be a big question. There is also this consideration to, as we move out of these prenatal fetal therapy trials, how do we think about the inclusion criteria that those trials were designed in, and how and who should we include now in those interventions after the trial? And these authors, looked at obviously there are good reasons why participation in clinical trials and inclusion criteria are created, and it's obviously to identify a defined population to ensure participants can participate in all activities, to minimize risks, sometimes maximize benefits, and to minimize untoward side effects. But expansion often should lead to more studies to expand that, but in fetal intervention, sometimes those aren't even feasible or even ethical. So there's considerations that arise around what makes sense to open it up and where that how do we balance those concerns around benefit and harm. There's also some considerations about inclusion criteria being somewhat exclusionary from an equity lens. And so these are big questions that a lot of field centers are grappling with about, are we excluding people who could benefit based solely on inclusion criteria that maybe was constructed very narrowly or very for good reasons, but very narrowly. And then who can access? And this is another big question. As a lot of these fetal therapies emerge, they can be pretty pricey and not always covered. But now we have an identified benefit. And not only identified benefit, but something pretty impactful for a child's and family's life. And so there's this big question then of who gets to access it and what is equitable, what is fair. And those factors, I think, are playing out quite significantly. Some of the folks here at our center put together this conceptual framework, and we found, looking at a panel of experts and review and some chart review, that there's a lot of contextual factors of people's ability or desire to even seek out fetal intervention or fetal health based on community norms and beliefs, fetal center attributes. There's obviously personal beliefs and social support, socioeconomic status. Most of the patients that we've been seeing, not surprisingly, have private insurance and are from very privileged areas. So most are from low maternal vulnerability counties. So there's low vulnerability where these are at. So there's some disparities in who's accessing these. All right, so finally, we're going to move into, okay, so we know all this. We've gone through some of the ethical principles here, some of the ethical concepts to understand how are we doing ethics in the fetal center. And I think this is an area that there's not a lot of literature on. There's a little bit, and get to continue to highlight Children's Mercy here because Dr. Carter and Shika Calavar, who wrote this when she was the fellow there, and in the same place that I got my experience, have been talking about this and a few others. And I know I've gotten calls from other colleagues around the country figuring out how do we do ethics in fetal health centers. It is a little bit different. I think there are unique ethical concerns, as Carter and Calavar pointed out here. There are these innovative procedures. There's concerns around whether these are novel or experimental, moral distress, adequacy of informed consent. As surrogacy laws around the world change, I think the U.S. is seeing a little bit, or we did see an uptick of surrogacy questions here in our fetal intervention centers. How do we think about procedures whose goal was palliative rather than curative, but entails risk to the pregnant person, rights and interests of the unborn, and parental capacity for decision-making? And I would say I've seen all of those in my practice here. I am a pretty involved part of our fetal center here, both in the operations, but also within consulting. And so how do I navigate clinical ethics and fetal health is partly on an operations side. So providing education, and some of this will look pretty similar to clinical ethicists. We provide a lot of guidance. So we have 2 case reviews, and ethics attends both of those weekly. One is a clinical case review. And, so talking through different cases that are coming up, and we have these conversations about risk to the pregnant person and benefits for the fetus, and how do we navigate those. I mean, just today on one of our calls, parental hope came up and how that impacting, and whether we should or should not intervene. We also have a palliative birth case review on some of our cases where there's potential for non-survival, non-intervention, and everything sort of in between there. We also are involved in operations in terms of policy and practice, and I'll go through some examples of these as well. And in research and innovation, sometimes the question is, which is it, or how do we do it? And then, of course, moral distress, consultation, and continuity, because since we are the pediatric ethicist in the fetal space, we can follow these patients postnatally in the special care nursery infant care center or NICU, and follow along with them. And so one operations thing that comes up is this sort of post-Dobbs idea of lethal anomaly and futility exceptions that really changed. And how do we consider if something is lethal anymore? Because there are interventions that used to be lethal, but now that have interventions that could sustain life. How are we considering this in terms of life limiting? And what we're talking about is really, is this acceptable to interrupt pregnancy, where there are some children who do survive? And so we've gotten involved and had conversations with our team and come up with ethics considerations around if non-intervention is appropriate based on a concept of proportionality, then if non-intervention is appropriate and chosen, it is thus a lethal condition. And so having these conversations, along with our neonatologists and our legal folks about just how do we navigate both federal and state considerations in practice. Another consult that came up here is which path is acceptable and when. So some of our case reviews, and this one specifically came up where we have a child with a fetal hydrocephalus and macrocephaly. So likely non-survivable, but unsure of how long. And so this led to a significant problem that the child's macrocephaly was so big, and I'm just glossing over a lot of clinical details here on purpose, just for the sake of presenting the case. There's an inability to pass through the birth canal. And so there's two options presented here from an ethical perspective, and the question of which one should we do. And one option is you could do an induction with C-section, but this comes with maternal risks. But it could allow for some time with the child, meaning that we could induce pregnancy early, do a C-section, and could potentially allow some time for parents to have with the child. But again, you have significant maternal risks with a C-section for this patient. The other one was a reduction of the hydrocephalus. So just to put it basically, putting a needle and draining the hydrocephalus, it would allow a vaginal birth, which would put the pregnant person at less risk, but it also could lead to in utero death of the fetus. And so the question came up to ethics of what we should do. And this really gets into this idea of, well, what are the goals, right? Because if your goal is to reduce maternal morbidity for future reproduction, then reduction in vaginal birth may be acceptable if the parents are accepting of the risk, because there is some potential benefit there. Like it could potentially work, though likely to potentially cause the demise of the fetus. If your goal from the parents was to spend time with the infant and have a comfort plan, then induction and C-section could be acceptable. So this is one example of something that ethics in our fetal center helped walk the team through in consideration. Another one is in our research and equity, and not just research, but our outreach. And we have a sizable Somali American community here. And if you saw our concept earlier, one of those barriers there is kind of community sense of appropriateness to seek fetal intervention. We spent a lot of time doing research and focus groups with our communities and really identifying some surmountable barriers to accessing beneficial treatment interventions for this community. So I think there's a good way that ethics can really get involved in designing some of the research in research priorities around who benefits. And this one actually led to us as ethics and the team meeting with local imams and really talking through some of the Islamic religious ethics of these things, and really then helping counteract some narratives that were preventing some prenatal care. And then another research project that I'm another shout out to Children's Mercy that led to a healthy debate between myself and Dr. Kokora, and Dr. Carter got involved on my side a little bit. Is this idea of questions of emergent delivery or premature birth or intraoperative resuscitation. Basically, this idea of open uterine repair, there's this small risk of emergent delivery, very small, but it brings up some interesting ethical questions around when is non-resuscitation appropriate. I think it brought up some important ways, and at least the two articles listed there that Dr. Kokora and I debated on, I think really expand the ethical analysis of this situation as a really novel one around, is this intraoperative resuscitation? Is this premature birth delivery room resuscitation? What exactly are we talking about? And it's really, it can be kind of not clear, because in getting back to our thinking of fetus as a patient, with open uterine repair, you now are actually sort of have a patient not completely separated, but is right there in front of you instead of covered by and surrounded by the sort of the moral primacy of the pregnant person's body. And so it does bring up these interesting questions now about, once, if there's emergent delivery, once the child is born, they're now a child that is due all the moral and legal considerations of being a child. What are our beneficence obligations? What other obligations do we have now that it is birthed? And this has led to some interesting thought here at our center. And this is a forthcoming paper that we've been working on, and just really expanding on, is there a need to look at this from a different lens around, where does the perioperative window end and the neonatal window begin in terms of intrauterine fetal repair, where anesthesia is crossing the placental boundary? Where and when would resuscitation be appropriate or obligatory, or not obligatory, at what point? And there's some considerations around fetal emergence and potentially requiring intubation at least, if not CPR. This, of course, gets even more complicated as the obligatory age of viability at which resuscitation becomes mandated at certain institutions is reducing to 24 weeks. Most centers now, all things being equal, on a infant with no comorbidities, are obligating resuscitation at 24 weeks. Most are at 25 still. And a lot of these surgeries like myomeningeal are done around 25 weeks. And so it brings up some interesting debates around when and where resuscitation might be obligatory. And then, of course, there's the future. The artificial womb is coming. As near as we can tell, it hasn't seemed to found any points where it's slowing down. Human trials, I think, are incipient. And so, there's going to be a lot of ethical questions around how is that trial done? If that trial is done, where? I suspect that fetal centers are going to be a big part of that. Those trials, I think that's going to bring up other ethical questions about when is somebody a patient, what is appropriate for that patient, now the sort of the fetonate, so to speak, not quite a neonate, but not quite still a fetus. How do we consider patienthood in that regards, in terms of now it is sort of a fetus as a patient separate from the pregnant person? China apparently is already working on pregnancy robots. Who should be taking care of these fetonates? These are all, I think, challenging questions that really come in, and going really back to all these ways of how do we think about patienthood in this population? How do we think about risks and benefits? How do we think about hope, disability, and technological imperative? And how do we provide fair access to these things? And that is the end of my talk, and I think I have plenty of time for questions.
Let me thank Dr. Wolfe on behalf of the Bioethics Center and my colleagues here. This was an excellent talk. You're getting lots of positive feedback. This is exactly what we want to be delivering in this series, and we really appreciate the time and effort you put into this presentation. We have 25 minutes for Q&A, and I want to bring on my colleague Stephanie Kukora to moderate that. And as a reminder, please type it in the Q&A and it will be read aloud. Go ahead, Stephanie.
Hi, Ian. So good to see you.
Hey.
And thank you so much for this talk. And even though you and I completely disagree around the necessity or obligations of fetal resuscitation during surgery, I am delighted by your work in this area. And I think that it's really cool to have different perspectives and different thoughts on this. So far, we have one question in the chat, though I hope more will start rolling in. From Kelston Ellis, we have, thank you so much for your talk. Could you please speak a little bit to pressures medical institutions may feel to innovate and progress the field, and how this plays into ethics and decision-making around fetal interventions?
Yeah, it's a really good question. And I think, I've had some conversations, you can kind of compare this. So I've had some conversations back when I was in Kansas City about this. And then recently with some sort of elder names in fetal care, and it is an issue. We had a symposium here. We kind of talked about this. Is that you see this specifically too in cardiac surgery centers and pediatrics, right? There's anecdotal sort of sense that these things are economic engines for the hospitals. There's a need, so it's not like that's the only thing, but there's a lot of prestige to it. And so I think there's a lot of administrative pressure, maybe it seems like a value-laden word, but interest in having these, and they do provide some pretty significant benefits. And so I do think that what the downside of that is that, right, these things, much like cardiac surgery centers, cost, there's a lot of overhead at the upstart, right? And I think, we've seen, a number of cardiac surgery centers in the news that potentially, maybe didn't have enough support as they should have and have had some problems. And I think, there's some potential potholes just for folks to look out to of like, okay, how many do we actually need of these, right? Because there's this thing in pediatric cardiac surgery, that sort of volume outcome relationship, right? How many of these do we actually need within, one community to at least keep up a standard quality level? I think that's a big one, and I think to do these well requires multidisciplinary teams. So it is a big undertaking. And so I think there can be, from an administrative side, a real big focus sometimes on, the administrative things that you want. And if you don't have all the people at the table, I think you can end up really kind of hanging people out to dry, or at least not providing, what you should for some of those considerations, right? And I think that's where you get into the time to be able to provide adequate prenatal counseling. Most of these families meet with surgery, cardiology, neurosurgery, neonatology, pain and palliative care, sometimes ethics, social work. And so I think there can be a view from this of like, this is really cool and flashy. It's obviously a good thing. Let's just start doing it without really doing it in a considerate way that supports your clinicians, but also supports your patients. And so I think we talked about this a little bit about, how do you, as the field expands, keep an eye on those kinds of considerations, so you don't have those kind of structural issues that end up falling down. I don't know there's an answer yet.
Yeah, I think the follow-up question Dr. Ellis had was, how can ethics specifically help in balancing, when there are these sort of differences in sort of stakeholders' priorities, I guess, in these situations?
I think that's good. And there's a number of places. So I think the Mayo folks have a paper out where they talk about their ethics advisory board for fetal, where they mostly look at like liminal cases. And I know a number of other ones maybe have like ethics committee review. I'm biased, but what we've done here, where our head of our group has really put ethics within the operational spaces. So we're part of their operations meetings. We're at different case reviews, and we have these conversations around, what should we as a program do? And I think we've also have a leadership administration that supports that really wants that ethics oversight. I think there's always a worry from ethics, are we becoming rubber stamps? And I think that's good to always worry about that. I don't think that's the case here. So much is in fetal is sometimes less about should we or shouldn't we, but how do we? And I think that's where ethics can really help on the upfront, on the processes. around, what is good prenatal counseling? Where are areas that we can continue to improve? How should we think about and balance hope and the technological imperative in these cases? When should we say no? Those kind of questions.
Okay, there's another question in the chat from Shukri Jamali that says, "Great talk, Dr. Wolfe. Is there guidance or a requirement for interventional fetal centers to have an ethicist as part of their care team?" I think we sort of halfway addressed that, but do you know of any requirements
I don't know
about
of any
that?
requirements, and thanks, Shukri. Shukri is a great leader in the fetal ethics space, and I did a lot of work with. So there's some bias in her saying it was a great talk, but and Shukri was here in Minnesota at one point, and unfortunately moved on. But I think was definitely valued by leadership. So there isn't a guidance or requirement. I think maybe should be the case. I think most of the bigger centers that I know of have a pretty robust ethics presence involved there, and there's some folks I think within the fetal spaces who have been championing that. But Shukri, maybe it's time we write some guidance.
I like it. There's another question in the chat from Allie Wayne, who was up until very recently a big part of our fetal center here. She asks, how does the lack of standardization across fetal centers weigh into the ethical considerations?
Yeah, good question. I think it does present some issues around access. It's hard because it's in our disconnected healthcare system. There's pros and cons for that, right? People can have choice. I think where one person might not offer a potential intervention and another one does, I think you kind of ask, well, should we really hold to that limit and make somebody potentially go across state lines? So I think it brings up, a challenge in fairness or equity. I don't know that that's always, because you get in a little bit of the problem of, if people don't think it's something we should do and they're standing by that, it's hard to figure out a time how you would make somebody do an intervention. I think the standardization that worries me the most is, I think it's something we've struggled with in healthcare in general. There was some certificate of need laws in some states, but I worry a little bit about the lucrativeness, not just financially, but from a prestige level, and maybe the need of motivating how many centers are in an area, and I think also focusing more on intervention versus prevention always troubles me some. So I don't know how to answer that exactly, except to say that I think the question immediately is like, what kind of standardization makes sense? I think there's some centers that have started tracking, when we're going outside of the mom's trial inclusion criteria, and I think that can be really helpful in terms of developing standards, because then you're sharing information. So I think it's reasonable for one center to say, gosh, we're not comfortable with including this far outside. But so then the answer is, well, how can we, for those centers that are doing it, how can we collect that information and share it so then we can broaden that out? If we're not going to do a trial to expand it, how are we gathering that information? You could almost think of that as like an open label trial. So then it does expand some standardization across the centers who are maybe a little more, I won't say risk averse, but who don't feel as comfortable expanding. There's BMI was one criteria for myelin indice repair, but there's a number of centers that have done surgeries on people with higher BMIs outside of the criteria for the mom's trial and have done just fine. So that's one place where I think standardization could really be beneficial. I think most of the other stuff, it would be nice to see some standardization about experimental or innovative therapies. I think there's been a lot of questions and difficulty in trying to figure out if it's something research and should go through the IRB, or is something really more just ethics oversight. And I don't know that we've really fine-tuned a lot of it. I think the Mayo's version of the Ethics Advisory Board is interesting. I think a number of other places have done similar things. And um, I think the bottom line is, how are you standardizing some sort of process of good discussion around some of these more liminal cases?
Excellent. We have another question from Fred White, who asks, given the Dobbs experience, do you think that the Roe 14th Amendment statement on fetal personhood will ultimately be reconsidered by the U.S. Supreme Court?
Boy, that's kind of a legal question that
A hard question.
maybe don't want to get into. I think what I will say is, I mean, right, it's complicated because morals influence laws. And so, I mean, I think I mean, I don't know that I would predict anything from the Supreme Court these days. So in that sense, I guess I have no idea what they're going to do. I mean, I think I worry a little bit about, we've already seen across the country, the use of substance abuse in pregnancy as a way to restrict liberty and autonomy of pregnant people. I think I do worry a little bit about personhood in a general sense, because I think it's important to consider how individual clinicians view personhood for their own sort of conscious and considerations, and then how the patients view it. I mean, at this point, I guess I'm just going to default to I have no idea what the Supreme Court's going to do.
I like it. Yes, I think none of us can predict at this point. Here's another question from Rebecca Benson, going back a little bit to what I think we were talking about, the question before, which is there more to say about how to think ethically about clinical trials in the fetal center space?
Yeah, I mean, I think those authors that I had in there have some good information about thinking about fetal trials. I mean, I think it does come down to some basics of ethics, which is, proportionality. It requires us to think about who is and when going to have that benefit. So one thing is like the fetal trial, right? I mean, it's not, well, it's not necessarily curative, but it brings up a lot of questions about risk and benefit. And I think so that the fetal trial is to occlude the trachea to hopefully provide better lung growth. And I think what's mostly been seen on the data now is that it doesn't improve the need for or reduce the need for postnatal repair of the diaphragm, but it does reduce the need for ECMO after birth. But it requires the pregnant person to be close to the facility because you need to do an exit procedure. So they need to partially birth the child to then remove that airway obstruction. So I think one way to think about clinical trials in the fetal space that's different is that there's that, again, sense of hope and technological imperative that I think requires us, though, to question about, hey, this might provide some benefit, but is that benefit worth it on a broader scale? And I think, I do think for feto that the reduction of postnatal ECMO for a fetus can be significantly beneficial. I think there could be other interventions that, like the RAFT trial, I think is questionable on, yeah, it is saving the child, but, with all of this other stuff. And I think the challenge for fetal trials is that we don't always know. And that's where I like the metaphor of whitewater rafting. And so I think there is a way, like, how do we think about this in terms of when we're innovating and whether something should then go to a fetal trial? How do we even do that innovation piece? Because so much of it is built on this information that we don't know what's really going to happen with it sometimes. And I almost think like maybe that's more of there needs to be more sort of these pilot studies or innovation attempts somehow regulated by some body of like, okay, this is theoretically possible. We are going to try this with somebody. But then how do you do that informed consent? How do you do all those things? When do we decide it goes, towards an actual trial? How do you even do a trial? I mean, is the DSMB setup and the IRB setup actually sufficient enough in the fetal space? So I think thinking about it ethically more for clinical trials in the fetal center space just requires, I think, a lot more at the bedside clinical trial monitoring and discussion about it and oversight that I think DSMBs probably can't do because of the sort of distant nature. I hope that made sense.
Okay.
That was kind of a big answer.
Yeah, no, it's a good answer. There's another question from Shuku Jamali, and it's actually very similar to what I was going to ask you. So I will sort of combine both of our questions. So the question is, how can we strengthen our advocacy for parents struggling with the emotional and ethical challenges of deciding on fetal surgery when it may come with a risk for the pregnant parent, who often wants what's best for the fetus? And my question sort of that builds on this is, we talk a lot about the technological imperative and like us feeling like we need to do things as clinicians because it exists and because it's technology and because it's cool. But I think that from the parent side, I feel like there's a lot of like self-sacrificial feelings of pregnant people. I mean, I can't tell you the number of people who've come to me and said like, let me die, but save my baby. And I have to be like, I have to tell you how that works. And that's not exactly like, that's something that's only in the movies. That doesn't work in real life. And so I feel like sort of, being willing to take these risks on might be a sort of social pressure that we perceive in society, and also like a sort of internal thing that's ingrained when you're pregnant and, going to, you really want your baby to survive. And so how do you see that fitting in, and how can we as clinicians make sure that they feel well informed and thoughtful in these decisions?
Yeah, I mean, it's a really good question. And I've sort of witnessed that over my course of observing fetal counseling, prenatal counseling around it, and it's really raw. I mean, you can see the emotion in parents, and it can be really challenging. I mean, I think you can take a little bit of a page from prenatal counseling from the neonatal space, right? So the neonatologists who do the delivery room counseling when somebody's in preterm labor. I mean, it's a really challenging space. There's not a lot of time. There's a lot of emotion. There's, a pregnant person who's in distress. I think what I've seen too is really, this is where I think clinicians kind of need to step back too. And this is where I think the fetus as a patient is really helpful in terms of considering that, but also then considering the concept of maternal-fetal conflict, because it and I don't know, so should I like that word, because I don't know if it's a conflict really, but it is kind of a tension where a clinician needs to understand, because that emotional appeal to a clinician, I feel like is a heartstring pull, right? And it might lead a clinician like, gosh, I want to do something for this person, and really trying to weigh those considerations. I think that's too where a multidisciplinary team plays in, because you get the fetal, the pediatrics people really focusing on the fetus and child, and you get the adult people focusing, the obstetric people focusing on the pregnant person. And so I think, for one, there's a room to step back, and I think this is where fetal case reviews are really important. Having a multidisciplinary case review where it's facilitated in a way that invites discussion and commentary is important to really challenge some of those emotional pulls we might have. I think then being thoughtful about, is the benefit to the fetus enough to justify that risk to the parent, just absent of the parent's considerations, right? Because I think we need to understand that, and this is where ethics can come in. I brought this up today in a fetal case of that emotional drive, that parental sense of duty, that I would sacrifice myself for my child, that sense of hope, and really looking at, is this a last ditch? Like, is this, like twin to twin? I think is a different example than myomeningeal, where we're say simply, but reducing disability versus saving one of the fetuses. So I think it's going to be really challenging. I guess my advice in the long run would be having thoughtful conversations with families about where that desire is coming from, but also as a clinician understanding that that is a thing. I think it'd be interesting to do more research around moral decision making around these things from parents' perspective. And I think having those thoughtful discussions as a team together to stand on a ground saying, we all agree that this is not a good idea to go forward when we don't think it is, in order to not allow our emotions to lead us to doing something that could potentially risk the life of the person with not much benefit to the fetus. I mean,
Yeah.
we do get those cases, as you probably know.
Yeah, absolutely. No, I think that where these feel very different is that if a parent begs me to try to intervene on their baby who I think has a terrible prognosis, like there's no other sort of otherwise healthy, person of reproductive age who's in the balance and getting harmed too. So it feels a little bit different there. But I think it is, yeah, it's a really hard consideration. And adults are allowed to make decisions that are not in their own best interest, but I feel like there must be a limit of what we are willing to offer if we think that the risks, don't confer the benefits that make it worthwhile. All right. So I think that wraps up most of the questions. In the Q&A, folks can find information about how to get your attendance recorded and get your CME credit for this activity. Please do that. It's important for your careers. It's good. It's good to get that since you've been here watching. And I just want to say thank you again to Dr. Ian Wolfe. I think you and I should maybe do some of this research. I think this sounds really, really cool. But thank you for your tremendous work and your very thoughtful presentation on this today. And we're so delighted to have you as one of our prestigious alums who is doing such cool work in this space and setting a good example for all the good work that has come out of Children's Mercy Bioethics Center. So thank you again. And everyone who's online, take care, get your CME credit, and we will see you at a future session.